Karnataka always feels like a second home. I've done my post-graduation MS from Mysore, and it's such a pleasure to be among all of you in this Karnataka societies, and especially the KCOG, because KCOG was one place where when I was doing my post-graduation, we had done our KCOG conference in Mysore under the leadership of Dr. Amrish Bandivat, who was the chairperson of the conference at that point of time. So first of all, my regards, respect to the chief patron, Dr. Hiramat sir, the president of KCOG, Kasturi ma'am, and thank you ma'am for the wonderful words. Dr. Bharti ma'am for being the secretary, and also Dr. Durgadas sir for being the treasurer. And of course, the office bearers of the Karnataka College, Hema Divakar ma'am, a respected teacher, Mulidhar Pai sir, of course, a teacher of teachers, Dr. Hiremat sir, Dr. Basavarajan sir, and Dr. Vidya Bhatt ma'am. My regards to all of you, and it's such a pleasure to join all of you today for this wonderful meeting. So I would like to, I hope my screen is visible.
Yes, it's visible.
Yes, sir.
Yes.
Yeah, sure.
Let's make it slideshow.
It's slideshow already made, ma'am?
No, it's not. No, it's not in slideshow.
Okay, I'll make it once more, ma'am.
Yeah.
Is it slideshow now?
No.
No.
Still in the, I think make it full screen first.
Okay.
And then slideshow. No, it's still in your grid view.
That's surprising.
Maybe.
It has to go for slideshow.
Lord, yeah, it doesn't.
Do it from here, this one.
Yeah, do it from there. It's okay. Yeah, do it from there.
Is it visible?
No, there's something wrong with your computer.
Oh, I'm so sorry.
It's okay. I think you can just expand it and make it full screen and then try again.
Not yet, right?
No, it's not yet.
Okay, then I'll just expand it and do it, ma'am.
Yeah.
This is better?
Yeah, better.
Yeah, that's better.
Very good.
Sure. So thank you once again for giving me this opportunity. It's such a pleasure to be among all of you in this meeting. And as I have already said, KCOG has a very special place in my heart. And it was as a student where I have been a part of KCOG, presenting cases at the BSOG as well as KCOG meetings, and talking here today to all of you on this adolescent endometriosis, underdiagnosed and undertreated, is giving me a lot of pleasure and goosebumps, I must say. So I will start this talk. So starting with the introduction, the American Society of Reproductive Medicine once stated, endometriosis is the presence of endometrial glands and stroma outside the endometrial cavity. We all know this. Stroma is more than the glands in adolescence, and endometriosis is an estrogen-dependent and progesterone-resistant chronic inflammatory condition. Now, first of all, giving a brief preface of this talk, I would just say one thing. Any patient or any youngster who comes to our OPD with pain abdomen should not be ignored and neglected. A common thing for the parents as well as for the doctors is, whenever a young girl comes to the OPD with pain, the first question that we ask is, when is your exam? Are you scared of giving an exam? Don't you want to study? Don't you want to go to school? Those are relevant questions, I understand, because during our days too, we have had abdominal pain thinking of bunking school. But then we also need to understand that in today's day, these girls might have these complications, or they might have this problem of adolescent endometriosis, because of which they are giving these complaints. So it should not be ignored. You should investigate. If everything is all right, it's well and good. But if something is wrong, we should catch it early and we should treat it to prevent the progress of the disease. So this is what I would say as a preface. Then further going on to the further the diagnosis, the management part in the subsequent slides. So in adolescence, the disease is often unrecognized, ignored, and mislabeled in the adolescent population, as I've just mentioned. Frequently results in chronic pelvic pain, adhesive disease, and infertility. There is no relation between the age and stage of the disease. Atypical presentation is more common. Early diagnosis and treatment may decrease the disease progression and prevent infertility, as it is a more aggressive disease than adult endometriosis. I'm really sorry, in between, actually I've come for another physical CME in Siliguri, and this is the hall that we are going to have it in, and there are a little bit of sounds here and there. I'm sorry, please ignore if there are any such disturbances in between. Yeah, so the prevalence among the teenagers, if you see, the overall prevalence varies between 5% to 10% in teenagers, 25% to 50% of girls with dysmenorrhea and atypical pain abdomen of chronic nature have endometriosis. It is seen in 50 to 70% of teenagers undergoing laparoscopy for evaluation of chronic pelvic pain and dysmenorrhea, and prevalence may be even higher when laparoscopy is done by senior endoscopists. Now, senior endoscopists, of course, we have a lot of senior surgeons around in the country. Plus, we have people who are youngsters and who have done a lot of laparoscopic cases who can also do diagnosis in a very nice way. But one thing to be mentioned over here, as said by Dr. Shafran in the last ESHRE conference, that only for diagnosis of endometriosis, we should not put in a laparoscope in the abdomen to see what is the problem if they have pain abdomen. If we are doing it for something else, we may add it on to our battery of tests that we can do to diagnose endometriosis. In today's day, with the advent of good ultrasound machines, a 2D or even a 3D ultrasound machine is wonderful for diagnosis of endometriosis. So we need to use those modalities first and not jump into laparoscopy as a first treatment modality. So what is the economic loss and why do we need to bother about adolescent endometriosis? 0.8 to 12.5 billion euros are spent every year according to the EndoCost study by World Endometriosis Research Foundation. The work, study, social, sexual relationships are affected in a huge way. 176 million women suffer from endometriosis worldwide, which is roughly 1 in 10 women. Now, this is 1 in 10 women reported. Now, just imagine the number of women who are underreported. Also understand one thing, if a woman comes to us in the OPD with pain abdomen and tend to come again in a period of probably a week or 10 days, please take it seriously. It takes a lot of courage, lot of strength, lot of motivation for a woman to come out of her house, leaving her household activities, leaving probably her child at home, leaving her work schedule and coming to a hospital to get herself treated. We should not lose this opportunity. Catch her right at the right time and diagnose it and treat it. 26 million women in India suffer from endometriosis, a figure that I would say was from 2016, and I'm sure there are a lot more women in this category at this current scenario. Now, what are the types of endometriosis in adolescent, as in adults as well, but more commonly in adolescents, I would say, is the ovarian endometrioma, the deep endometriosis, and peritoneal endometriosis. So, to diagnose these modalities, peritoneal as well as deep endometriosis, it's very important for us to probably get an MRI scan done to diagnose these modalities. But our ovarian endometrioma, a 2D or a 3D ultrasound will do wonder in probably diagnosing an ovarian endometrioma. A study on advanced stage endometriosis in adolescent and young women, which was published by Naum et al., stated that stage 3 or stage 4 endometriosis is seen in almost 20 to 23% of young girls. In adolescents and young women with endometriosis, advanced stage disease is not uncommon. Please understand this, understand the severity which a woman goes through, and then only go ahead and treat the woman accordingly. It is mentioned in Novaks and Berek that once a doctor or a lady gynecologist suffers from endometriosis, will they understand the suffering that a patient goes through, so that you can diagnose it correctly, not mistreat or not tell her that why are you coming repeatedly, there's nothing that is diagnosed. Understand there is a component called peritoneal endometriosis. Understand there are other components which can be like deep infiltrating endometriosis, which will cause severe pain and should not be neglected often in this woman, also in adolescent girls. Now, what are the risk factors for adolescent endometriosis? It could be early age of menarche, less than 12 years of age, deep dyspareunia in sexually active girls, pain interfering with daily activities, severe dysmenorrhea with OCP is used as analgesic and not as contraceptive, family history of endometriosis, girls with low BMI, frequent and prolonged cycles, early age of menarche, as I've already mentioned. Now, the postgraduates who are present over here, this is an MCQ question that you might get. Family history of endometriosis, what is the risk factor for the girl? It's almost 6.9 times higher in a girl who has a family history of endometriosis, especially in first degree relatives. Now, this was published by Ivo et al., the risk factors for adolescent endometriosis. We probably do not need to quote him, but I quoted him because this was one of the first studies that talked about adolescent endometriosis. Presence of neonatal uterine bleeding may represent a warning sign of future development of endometriosis and increase the awareness of devastating disease in young women. Now, the postgraduates who are present over here, I would like to mention one of the things here that bleeding PV, we know that can happen at a very young adolescent neonatal stage, maybe just after birth within 4 to 5 days is considered to be normal. We all know that, right? Because of the fact that there can be some estrogen and progesterone imbalance in the body, which has been present in them from the maternal side, that will suddenly go void, and because of that, some bleeding may happen. But remember, this is a risk factor. A neonatal uterine bleeding is a risk factor for adolescent endometriosis later on in their lives. Now, school absenteeism. This was a study by Letizia et al., which talked about dysmenorrhea, absenteeism from school, and symptoms suspicious for endometriosis in adolescents. It affects the quality of life, affects future fertility as well. Now, how do you evaluate adolescent for pain or for endometriosis? Look at the history, look at the examination findings, the imaging, as well as the biomarkers, and they are all challenges in diagnosis of endometriosis. Now, history. What are the key components that you look in diagnosing endometriosis? Could be pain, daily activities which could be altered. There could be family marital history, sexual history, or contraceptive history, which you have to take. There could be PID or psychiatric treatment which a patient is undergoing, or bowel and bladder symptoms which may be prevalent in these ladies. Now, what is the bowel and bladder symptom that you may talk of? Sometimes you, even in an adolescent girl with the advanced disease, you will see that these ladies will sometimes complain of blood in stools during their menstrual cycles. Now, do not ignore it. Do not think it's always a menstrual bleeding that is probably gone posterior and caused some bit of bleeding in this pain or bleeding in these patients. Do not ignore it. Examine it. Send the stool probably for an examination and test whether it is blood is there. And that could be one of the findings or one of the points that you could take it forward for diagnosis of adolescent endometriosis or endometriosis through the peritoneal cavity. Now, key components in diagnosis as per the history, as we have mentioned, bowel and bladder symptoms, do not neglect, and I'll mention it again. And hindrance of daily activities, another point that you will need to remember when we talk of this. Now, what are the cyclical symptoms that we can talk of? Cyclical and acyclical pain, that is around 63% of women. Cyclical pain, of course, we understand in endometriosis will definitely occur. And in acyclical pain is usually seen in cases where there is a peritoneal endometriosis or where the endometriosis is a deep infiltrating endometriosis. Cyclical pain alone can be 9% of cases. Acyclical pain can be in 28% of cases alone. And irregular menses can be present in 9% of patients. So cyclical and acyclical pain combination is usually seen in cases of endometriosis, and this can be more so seen in case of adolescent endometriosis. The other factors that we can think of could be UTI symptoms, dyspareunia, GI symptoms, as well as vaginal discharge that we can think of as other symptoms which could be present in case of adolescent endometriosis. Now, physical examination. What will you see in a physical examination? Rule out any ovarian pathology and Mullerian anomaly. Mind you, Mullerian anomaly has got a very high predisponence for endometriosis, especially adolescent endometriosis. All the hematometra, especially in cases where the cervix is absent and the uterus is present with a endometrium, with a functional endometrium, you will see cases where you'll have hematometra inside the uterine cavity, which will probably by retrograde flow go into the fallopian tubes and into the peritoneum, and that can further on form endometriosis in the pelvic cavity. Abdominal and rectal examination needs to be done. You need to do a Q-tip test, which is more of a theoretical test, but can be definitely mentioned. And 32% have uterosacral nodularity and endometrioma. Nowadays, the youngsters, we talk of maybe the ultrasound probe as being our hand and as our fingers. But I was just talking to my dad the other day, who's also a gynecologist, and he was telling me in their days, the fingers were the ultrasound probe as well as the laparoscope that you can think of. Do not forget your clinical skills. Whenever you're diagnosing a case, whenever you're a patient with adolescents, without any adolescent girl without any without any sexual activity or without any sexual contact, where you cannot do a per-vaginal examination, always make sure you do a per-rectal examination, because a per-rectal examination will give you the nodularity on the uterosacral, which will be in favor of diagnosis of endometriosis. Now, therapeutic trial in adolescent girls with dysmenorrhea or chronic pelvic pain. There could be a couple of things that we could talk of, and this was published by Sperov in his clinical gynec endocrinology and infertility book in 2010, where he talked of NSAID, OCP, or GnRH or Dynogest, which could be given for this woman, and subsequently, if the pain decreases, that could go ahead and prove that this lady is suffering from endometriosis. Now, what are the ultrasonographic findings that we will be looking at? Unilateral or bilateral kissing ovaries, unilateral or multilocular cyst, thin or thick septae, mobility can be restricted, elicitation of site-specific tenderness, mural echogenic foci, lower level internal echoes, and posterior acoustic enhancement called the ground glass appearance. Ground glass appearance is ideally diagnostic of endometriosis, and whenever you see a ground glass appearance on an ovarian cyst, you will diagnose it to be a endometriotic cyst. Now, these are a few of the images of a 3D, 4D, or a color Doppler, which could help you differentiate between a dermoid cyst or help you differentiate between a dermoid cyst and endometrioma. It can differentiate adnexal pathology, acute hemorrhagic cyst, dermoid, or a neoplasm. Blood flow in endometrioma is usually pericyclic with resistive index above 0.45. CT scan has got a very limited role and should not be ideally done as a first-line investigation in case of endometriosis. Endometriomas may appear solid, cystic, or mixed. Because of poor specificity and high radiation, CT scan has been replaced by MRI, and I would say MRI has also been replaced by laparoscopy has also been replaced by MRI in diagnosing endometriosis in adolescent girls and otherwise. In CT scan, it has got very limited role, especially in case of lung endometriosis, scar endometriosis, endometrioma, and also it could be talked about a virtual colonoscopy, but has got very limited role in the current OBGYN scenario if you look at. MRI. It is useful for adolescent girls who are not sexually active for diagnosing endometriosis. Remember and understand, the best modality that you have today is your fingers for clinical examination. Number 2 is your ultrasound probe or transvaginal probe, which will give you the best diagnosis. Remember, transabdominal probe is not as good and should ideally be not done for diagnosis of endometrioma. In case if you are suspecting something, you could probably do a transrectal or a transperineal ultrasound, which is also even better. And if not, if it's affordable, then maybe you can get an MRI scan done. Must in DIE before surgery is planned by the team of urologists, gastroenterologists, and a laparoscopic gynec surgeon. The T1 and T2 weighted images along with fat suppression for T1 image is taken along with the gadolinium contrast. Endometrioma, the ideal is USG. Only doubtful cases get an MRI done. The specificity and sensitivity is 90% and 98% respectively. But understand, if ultrasound can do the job, do not get an MRI done unnecessarily. So how to optimize the diagnosis of endometriosis? This was what I was talking of, the slide by Saffron in 2019. Necessary to change the paradigm. In 2019, there was no place for diagnostic laparoscopy when endometriosis was clinically suspected, and this was stated by him in the ESHRE conference. Please understand and remember, do not perform diagnostic laparoscopy only for thinking when you're suspecting endometriosis. Get a good ultrasound done or get an MRI done, and that will be more than enough for giving you a diagnosis of endometriosis, and you probably will not have to do a laparoscopy for this patients. Now, what is your goal of therapy? Primarily, of course, pain relief, arrest of progression of the disease, and prevention of fertility. The primary 3 things that we will look at when we are talking of adolescent endometriosis. Now, what is the concept of medical management? It starts from suppression of the estrogen to reduction of the retrograde spill, overcome the progesterone resistance, anti-inflammatory effect, aromatase inhibitors can be supplemented, anti-angiogenic activity, and immunomodulation, which can be done. So what is the ESHRE and the Cochrane collaboration state for NSAIDs for pain is quite effective. Least effective dose administered either before the onset or before the peak of the pain. Mefenamic acid, ibuprofen, naproxen, or COX-2 inhibitors can be given. Side effect, of course, we know is gastritis, but NSAIDs for pain is one of the things that has been used, and it can be given in the least effective dose for the least side effect like gastritis to occur for our patients. Combined oral contraceptive pills is another thing that can be supplemented, but we need to remember for a young girl who's maybe 15, 16 years of age, do you want to give COC pills is something that we need to think of. Continuous OCP for 3 months, relief of dysmenorrhea, query safety in adolescent, as I've said, because in adolescence, we know that there may be fusion of the bone, fusion of the epiphysis that can occur when you're giving combined oral contraceptives. And that is something that we can avoid if it's a possibility, because we have wonder molecules nowadays that can be supplemented in these patients. Isn't endometriosis an estrogen-dependent chronic inflammatory disease? Progestins instead of COC should be the first line medical treatment for endometriosis, and this was by Casper et al. In 2017, where they proved past use of COC was associated with higher incidence of disseminated intraperitoneal endometriosis. Estrogen in COCs may stimulate the disease progression. Thus, the ESHRE guidelines stated clinicians are recommended to prescribe hormonal treatment that is with level B evidence, but progestrogens with level A evidence, and anti-progestrogens and GnRH agonists as well with level A evidence for this patient, especially with adolescent endometriosis. So the role of progestins in management of endometriosis, if you look at newer progestins such as Dynogest, should be considered for use as a first empirical medical treatment. So understand and remember this thing. In today's day, if you look at NSAIDs, maybe the first line, but the present guidelines by ESHRE as well as Cochrane, etc., state that for adolescent endometriosis, Dynogest is a wonder molecule that can be used for these patients, and this gives wonderful benefit for these patients, because with Dynogest, it can be continued for a longer period of time, and it does not have much of side effects for this patients, as I must say. Dynogest can be used without any much of interruption. The maximum the study that has said as of now is for a use of 5 years, and that is a very good time for the suppression of the disease that can be used for this adolescent endometriosis patients. So as I mentioned, Dynogest is a newer progestrogen. It has selective 19 NOR and progesterone activity. Dosage is 2 mg per day. It has anti-proliferative, anti-angiogenic, and anti-inflammatory property. Pain relief is comparable to GnRH agonist, has minimal side effects, good safety profile and tolerability, and can be used for a longer period. This was a study which has initially introduced Dynogest to the world. That is a Visado study, Visane study to assess safety in adolescents. Multicentric single-arm open-label study conducted in 21 centers in 6 European countries, which stated safely offered to adolescents, can be used for a period of 5 years, immediate return to fertility, cost-effective in comparison to GnRH analogs, and there is no reduction in BMD, no hot flushes, and good relief of pain. Now, Visane is one of the molecules of one of the companies which is also supplying the medications in India, and you will be surprised to note that this company, as of now, also for 2 months of medication which a patient buys, the 3rd month the patient gets it for free, which is a wonder initiative by this company still. Now, GnRH agonists, I put in the picture of Zoladex. There is no commercial benefits that I have from any companies for this presentation, but this is one of the commonest commonest medication that we use for our patients. So it used for down regulation of gonadotrophins, used in girls beyond 16 years of age, given for 6 months. Remember, 6 months is a limit when you're using GnRH agonists, and please never use it without add-back therapy. It's a must for you to give add-back therapy for these patients. Side effects could be hot flushes, vaginal dryness, decreased libido, as well as osteoporosis. LNG-IUS. For adolescent endometriosis in India, whether you'll use it or not use it is a second thing, but in foreign countries, LNG-IUS is used in very common in the foreign countries, because of the fact that the girls there are probably get into sexual activity a little earlier than what it is allowed in as an official age in India. It is the second line of management in endometriosis with severe dysmenorrhea. Effect is multiplied if LNG-IUS is inserted following a primary surgery. It has contraceptive benefits and reduced EAPP. The effect is comparable to GnRH analogs with a continuation rate of almost 60%. Now, when I talk of LNG-IUS, there are 2 things that I'll talk of. Number 1, in today's day, there is no single treatment modality for endometriosis that is successful. If you do only surgical management, be sure the disease is going to come back in the next year to 2 years at the most. Remember, additional therapy, even if you're doing a medical therapy, probably the patient might need a surgical therapy subsequently. But This treatment, which is a symbiotic treatment, both being done together, surgery with a medical management, is wonderful. And after a surgery, a LNG-IUS that is inserted goes a long way in preventing any relapse of disease that may happen in these patients. Secondly, for patients who are sexually active, LNG-IUS is a device which gives protection to endometriosis and adenomyosis for 7 years, but for contraceptive benefit, it gives benefit for 5 years again. So it can be used for these patients as a contraceptive benefit as well. In today's day, if you see the LNG-IUS, one of the companies from abroad, which is initially brought this medication and patented the medication initially, supplies this LNG-IUS for a cost of only rupees 3,600 only. I'm mentioning this price over here because I'm sure for a period of 5 years, whatever combined oral contraceptives you may give, whatever NSAIDs you may give, you will not be able to reduce the cost lesser than 3,600 for these patients over a period of 7 years with excellent benefit, without the thought process of whether there'll be compliance or whether the patient will become non-compliant subsequently. Now, what are the newer drug therapies that that are there now available? GnRH antagonist, we have elagolix, we have progestins, SPRMs, as well as SCRMs, which will probably come in the near future and will be very, very beneficial for our patients. Just like to talk of a couple of things which we had thought had been out of the market, but is coming back now again, and probably in the next few years, we'll get it in India as well, is a re-emergence role of danazol in endometriosis. The danazol vaginal ring, which supplements 1,000 to 2,000, 1,500 to 2,000 milligram of danazol, useful especially in cases of disseminated intraperitoneal endometriosis. Pregnancy is possible with the danazol vaginal ring, and the low dose regimen or vaginal danazol is preferred. We have stopped using the oral danazol. I'm sure none of you are using it nowadays, but this vaginal danazol, the main advantage is it's a low dose regimen, and secondly, pregnancy is possible with the danazol vaginal ring with suppression of endometriosis at the same point of time. Now, there's another device, an intrauterine device releasing danazol, which is 400 milligram of danazol IUD, inserted within 7 days of LMP, lasts for 6 months, reduces dysmenorrhea, dyspareunia, etc. And the androgenic side effects can be avoided when it is inserted in an intrauterine device. Now, what are the other newer strategies? We have already talked of it. GnRH antagonists, aromatase inhibitors, SERMs, SPRMs, monoclonal antibodies, prostaglandin receptor antagonists, and dopamine agonists. I don't know how many of you have started using cabergoline in case of endometriosis, but in endometriosis now 0.25 milligram once daily given for a period of 1 to 2 years is doing again wonderfully in case of endometriosis, and has been published in studies now, and I'm very sure it will start getting used very routinely in our day-to-day practice. This is what I have already mentioned. Dopamine receptor agonist acts by binding with the VEGF receptors, very effective in treatment of disseminated disease. Dosage is 0.25 milligram daily once till some symptoms subside. Now, for all the postgraduates who are present over here, please understand and remember one thing. Once you are out of your post-graduation, probably you have done your fellowship in laparoscopy and you want to get your hands hot by doing laparoscopic surgeries on your patients. Please remember, a small endometriotic cyst, 2 to 3 centimeter, 4 centimeter, ideally does not need any treatment. Please do not do the harm by making a puncture in the cyst, draining that endometrial fluid into the peritoneal cavity. By that, it will just spread intraperitoneal endometriosis, and there will be no extra benefit for the patient. Remember this, only do it when the size is bigger than 5 centimeter. That is the cutoff that is given today. 5 centimeter for endometriosis is the cutoff. And if the patient has symptoms, that is only when you need to intervene. Do not intervene in endometriosis otherwise and spread the disease and cause harm to your patients. Medical management is a very, very beneficial modality now, and you can use this modality for benefit of our patients nowadays. Elagolix is a newer antagonist. It is the oral gonadotropin releasing hormone antagonist used for EAPP. FDA approved drug. Dose is 200 milligram twice daily, can be used up to 24 months. BMD reduction occurs when higher dose and longer duration of treatment is used. But elagolix, I'm sure, will be in the Indian market sooner, and we can use it for the benefit of patients as well. Now, is there any place for expected management in asymptomatic patients? This was a study done by Mahmood et al., and they proved that they stated that there are no trials that were available. 27% may show regression in early endometriosis, 67% may progress, 6% will remain static, can lead to future infertility. This area should be addressed in the future. Now, when to operate is $1 million question. You operate, do not operate when you're trying to do a diagnostic laparoscopy just to diagnose endometriosis. Number 2, do not operate when it's a small cyst draining out the fluid into the peritoneal cavity and thinking you have done good for the patient, but in the contrary, you have done bad for the patient. So operate in patients where the patient has chronic pelvic pain, you have a mass, etc., dysmenorrhea, which is not responding to NSAIDs, OCPs, or dynoges, that is the medical management that is available. Endometriosis associated with Mullerian abnormalities, emergency situation in endometriosis like rupture of endometrioma, and recurrent endometrioma with severe pain, large size, not responding to treatment, and suspicious of malignancy. Please remember that endometriosis in today's day, when you treat, it's another statement that is stated that endometriosis should only be treated or should only be operated only once in a lifetime. So do a endometriosis surgery in expert hands. Do not try to make it experimental for your patients, because it will cause harm to your patients and not benefit to your patients. Pre-operative evaluation, what do we need to do? We need to get an AMH level done. Detailed imaging studies are a must. Experienced surgeon should operate, and laparoscopy is preferable. Laparotomy is now more or less out of the question that we can talk of. Principles to be followed during laparoscopy: aim at eradicating the lesion, maintain ovarian reserve and promote fertility, relieve the pain and prevent recurrence. So the important things are relieve pain, prevent recurrence. Prevent recurrence how? Only surgery may not be good enough. You need to combine it with additional modalities like medical management, and both together will be wonderful in preventing recurrence for these patients. Now, endometrioma surgery, whether to do a more radical surgery which will impair the ovarian reserve, or make it less radical, because that will cause recurrence. So you need to walk on the thin line. You need to understand where to stop, how much to do. That will be important for your patients. And always remember, combine it with a medical therapy, because that will give the best benefit for your patients. Post-op medical management, as I've said, always cover it up with a medical management, anti-angiogenic drugs, GnRH, OCP, or an aromatase inhibitors. You can definitely, as aromatase inhibitors, letrozole is something that has again come up nowadays and is used in case of endometriosis. And you can probably give dynoges as well for this patient for continuous follow-up for a period of 5 years till they probably wants conception, and you can continue the medication till then. Follow-up is very, very important. Long-term follow-up is needed. Recurrence may be from 30 to 51% within 5 years. Medical adjuvant treatment is needed. Antiprogestins or OCP can be initiated at an early stage to reduce the morbidity, disease progression, and infertility. Adolescent must review once in 6 months. Evaluation should be done in their symptom recurrence or disease recurrence. Counseling is a must for the teenagers. Very important, counseling, because our teenager girl, whenever you put on medication, might not continue the medication if the patient is not counseled well. It's important for you to counsel the parents as well, because once the parents are counseled, they will follow up with the child and they will make them take the medications continuously. Few things that you need to say a no to for prevention of endometriosis, as well as prevent the progression of the disease: dairy products, refined sugar, meat, wheat, white flour products, soya byproducts, caffeine, saturated fat and oil, acupuncture, and Chinese herbal medications. Now, seeing this list, some of you might think, then what will we eat? You have told a no to everything. But I do not want to tell a no to everything. Reduce the quantity that you eat. It's very important for you to decrease the weight, keep things under check, so that it does not go out of proportion when it will become very difficult for you to control, or it will come to a stage where your fertility might also get affected. So can we prevent adult endometriosis if we treat adolescent endometriosis? The answer is no, but definitely the progress of disease can be delayed. We can delay the progress as much as possible, probably till after fertility, and do not do any unnecessary intervention in a patient with adolescent endometriosis. Any unnecessary intervention will lead to decrease in the longevity of the patient towards a healthy life, healthy sexual activity, and also towards a healthy fertility life that she would have otherwise enjoyed. So I would like to thank you again for this patient hearing, and thank you for giving me this opportunity to be with all of you in this KCOG chapter and sharing my thoughts on this topic. I'll be here for any questions if there are any, and thank you so much once again for this wonderful opportunity.
Dr. Priyankur Roy, it was a rapid fire session with all the questions answered. We congratulate you on this excellent talk with all the recent advances. And the information you gave about danazol and the danazol in IUCD, which is going to come in, is interesting. And I would request on a personal note to kindly share the reference. I would just like to go through that. We have a question from Dr. Yukti Bharadwaj. Can oocyte cryopreservation be offered before operating these girls?
See, the thing is, you need to understand that when you're trying for a oocyte preservation, you can definitely try. That is an option that is probably there, that they do it in the Danish, Denmark. Denmark is doing oocyte cryopreservation in cases of endometriosis as well. But in our country, we need to understand one thing. See, when you stimulate a girl with endometriosis, probably a big endometrioma, the oocyte quality is going to get affected. Also understand, when you put in a needle, when you're putting in a needle through an endometrioma, subsequently the oocytes that you pick up will get affected and the quality might not be so good. You can definitely try it out, but remember, the best thing to do is probably, if you have to operate on that patient and then stimulate the patient for best results. While operating, the important things are, do not cauterize too much. That is a very important message that we should give. Cauterizing wastes more follicles than what you waste by probably doing a cystectomy. And you can, if there is any bleeding, probably put in a suture there, which will cause less harm to the patient rather than cauterizing those areas. But I would say, in my personal experience, operating first, if it's a big endometrium of 7 to 8 centimeter size, and then doing a stimulation. If it's a small one, you can probably go in with stimulation and then go for an IVF cycle and then subsequently plan for it. Always, you do not need to operate also. In some cases, you can give suppression and followed by a transfer, and you get positive pregnancies as well.
There is another question from Dr. Naveen, but I'm exactly not able to get the question. He said, I'm asking him to rephrase the question. He says, are the drugs in the clinical phase? Does he mean
I think he talks about the recent advances.
Okay.
Yeah. So, sir, if that's your question, then I would like to say, no, these are drugs which are few of them which are in the clinical trial phase, and few of them which have already come into the market. The danazol ring is still in a clinical trial phase, and 2019 this was what was talked of. But then Dynogest, of course, we know is in the market, and there's nothing to talk about that right now. But cabergoline, letrozole are already in the market, has been used for other causes, and is also used in the market, and is also a FDA approved drug for endometriosis now, and can be used for these patients. Elagolix is a newer antagonist, not for endometriosis used right now, but we definitely know in foreign countries it's used in case of antagonist cycles in IVF, but I'm sure it will be wonderful in endometriosis as well.
There's another question, Dr. Priyankur, from Dr. Betty. After 7 years of IUD or Dynogest, what do we do? Do we switch her over to other drugs throughout her life if she is symptomatic?
Okay, so sir, Dr. Betty, the question that you say, after 7 years of IUD or Dynogest, what do we do? Yeah, so basically the thing is, it depends on what she wants. If she wants fertility at that point of time, you're going to stop your Dynogest, or you're going to take off your IUD and allow her to try for conception. If she does not want, then probably, if you're giving her Dynogest, then you could probably put in an IUD for this patient for another 5 to 7 years. And if you put her on IUD for 7 years, you could put her on Dynogest for 5 to 7 years. Remember one thing, this is wonderful thing that we are doing now. That is, if you put in an IUD, LNG IUS initially, in the initial 3 to 6 months, we all know that there can be chances of breakthrough bleeding that is there usually. That is one of the important counseling points that we need to do for our patients. Otherwise, they're definitely going to come back to you asking for removal of that LNG IUS. During this situation, it's very good or very nice to put a patient on Dynogest for 3 to 6 months. That covers the breakthrough bleeding as well. And after the 6 months, when the patient is set, you can stop the Dynogest and leave her on the LNG IUS for the next 6.5 years. So the answer for you would be, if it's on one modality, you can change over to the second modality, and vice versa. But if she wants fertility, stop both and she can try for fertility, because fertility comes back instantaneously almost.
And Dr. Rajeshi Palladi congratulates you and wants to know, what about Dynogest with estrogen combinations?
Ma'am, again, this has come to the market, we know, for some time, but it has not been very popular because of the sole reason that endometriosis is an estrogen dependent condition. And once we give estrogen, once we supplement estrogen, it might not work so wonderfully in these patients. So not a favorite for me, but I know there are many of us who use this molecule in the market still. But then for me, it's a plain Dynogest which does wonder, and I use this molecule.
Yeah, I am in consensus with you that plain Dynogest does have excellent results when we use them judiciously. I think I would go by that. And one more question, Dr. Priyankur, that when we start treating them on, or we do a laparoscopic surgery, and recurrence is a rule most often. most often. So is there any particular consent or something that we need to put it across and say that there may be a recurrence? Because very often somebody may come back and say, you did the surgery, why am I having it again?
Yes. So for this, the two important things I would say is, number one, do a AMH prior to the surgery and do one after that. Second thing is, after you have done your surgery, because we do not allow our patients' relatives in the theater, it's good to do a scan before you discharge the patient. Because as you said, the rule is endometriosis is there to come back. And once it comes back after 6 months, when the scan is done, they might say, maybe you did not remove anything at that point of time.
Exactly.
Get a scan done then to prove that you have done a surgery at that point of time, but it has come back. But to prevent that, ma'am, definitely a consent is a must, because we have to say endometriosis might come back. And during the period before it comes back, we should try for her conception. That would be a good thing. But put her on a medical management for 6 months for suppression. That goes a long way in preventing the recurrence, or at least delaying the recurrence by a considerable amount of time.
Yeah, I think post-operative medication does help. And Dr.
My favorite, actually, if you ask me, I would say LNGIUS post-endometriosis surgery is my favorite.
Okay.
Yes, because it keeps the patient a lot comfortable without any compliance. And whenever she wants fertility, just pull it out, and next month onwards, she can try for conception.
Sure. Thank you. Dr. Jayaraman Nambiyar wants to know, can we use tricyclic artery OC pills or special OC pills?
Normal combined oral.
Regular ones. Yeah.
It's good enough now. We do not need to use these things up.
Yeah. So I think Dr. Priyankur has another meeting, a physical vibrant meeting again to attend, and he has very well explained and brought it across with all the guidelines of the management of adolescent endometriosis. And we have our president, Dr. Kasturi Donimat, who will be giving the concluding remarks.
Excellent talk, Dr. Priyankur. Everything in detail you have done regarding adolescent. It's a difficult topic, I know, difficult patients to handle, but very well done. And every details, and especially I like the sentence, only one surgery in a lifetime.
Yes.
If we remember that, then we'll be very, very meticulous in selecting the cases, because sometimes I see the younger people, like they just want to post them for surgery and spread it more, without the knowledge, thinking. And patients also sometimes will be insisting that it has to be removed and all, but never. Only one surgery in the lifetime. Till that time, whatever excellent you have put, so many conservative methods, we can try all that, and years together we can do that safely. So thank you very much for a very, very excellent take-home messages on this adolescent endometriosis.
Thank you so much, ma'am. Just one more thing I would like to say is, for the youngsters, a special message I would say: do not burn your fingers in an endometriosis case, because it is something that will come back, and that will really be not good for your career ahead. Also, choose your cases very meticulously and operate only when it needs to be operated with good expertise.
Exactly, good expertise is very, very important in endometriotic laparoscopic surgery, I would say.
Yes, excellent. Because most of the time when we put a scope, we see that it is either rectovaginal, rectum is involved and all. Only if we have that expertise handling the bowel and all, then only they should do it. Otherwise, not.
Yes.
I think and the 3D ultrasound, the 3D ultrasounds will give us very good images, so that we can decide.
3D TVS ultrasound, and also the thing is, it's very nice when now this methods of butterfly technique, the discoid technique for the bowel, etc. has come quite nice. So basically, do it only when you're expert in it, or at least have someone with you when you're doing the surgeries. Do not try it alone. Just puncturing the cyst, draining out the endometriotic fluid in the peritoneum, and maybe harming her more than what benefit you're doing for her.
Yes.
Thank you. I know, Dr. Priyankur, you have to go for the next meeting. So without wasting much time, we thank you for spending time with us. I request our treasurer, Dr. Durgadas Sastrana, to kindly propose the formal vote of thanks. Dr. Durgadas, I saw him there.
No, but he's not well, Bharti. He's
Sir is there. Sir he came back. I just saw him.
Yeah, he's there. I can see him. Yes, he's there. Dr. Durgadas, Usha, unmute, please.
Unmute.
You continue. Then I joined.
Okay, sir.
All the best. Priyankur, you have done an excellent job.
Thank you so much, sir.
I'm sick. I cannot join. Okay. Madam, Bharti,
thank you, sir. Wish you a speedy recovery, Dr. Durgadas. Thanks for being there with us. So on behalf of Karnataka State OG Association, I extend our deepest gratitude to Dr. Priyankur Roy for having been with us and talking to all our delegates about adolescent endometriosis. I thank our president, Dr. Kasturi Donimat, to joining this webinar in spite of her busy schedule. I thank Dr. M.G. Hiremat, Dr. Muralidhar Pai, Dr. Hema Divakar, Dr. Vidya Thobi, and Dr. Vidya Bhatt, in spite of not being able to attend. It is under their guidance that we are having such successful programs going on and keeping our consultants updated. We thank all of them for their excellent gesture that they have taken, and I thank all the delegates. And I have a special thanks for Dr. Krishnananda Malya, a senior professor at Manipal Institute of Health, and he is always there. He is always there, and he is an example to all our young consultants that whatever busy, wherever we may be, if you have a will, there is a way. And updating knowledge and being on the track is what is required for women's health, and that's the way we should go. Thank you very much, sir, for being here with us. Thank all the delegates. Wishing you all again, may Krishna come home and bless all of you. May you have a great weekend. Good night and goodbye. Thank you. Thank you.
So much once again.
Thank you, everyone. Yeah. Thank you.